actually the talk with the congenital leg deformities is actually fairly, it's not too involved. But I think behind it is maybe something that's more important is a little bit about embryology, which paints the scene to how congenital anomalies occur, why there are differences perhaps between upper limbs and lower limbs, for example, why, for another example, why amniotic band would not be associated with generalized abnormalities, whereas, for example, radial club hand maybe. And I just think that maybe it's an opportunity to have a look at that. So there's the talk, and that's going to be Tibial Aplasia, Fibula Hemimelia. And so that, if you can see my pointers here, there's the embryology bit, and then I wanted to spend a little bit of time on the format, which is going to become increasingly important, of the single best answer. And so, Michael, I think as seniorage, we can start in any of these places and then jump back. My suggestion is that we get tonight's topic out of the way, stop there, maybe run through the questions, stop there, and then perhaps come back and do the embryology, which may be background but not core. Does that make sense, Michael? I don't see you.
Yes, makes sense.
Makes sense. So let's go to the congenital limb stuff. Let's start there, and then let's just start in a place that says, well, we need to, I suppose with anything in medicine, we need to start with a diagnosis, and a diagnosis is going to point to a pathology, an underlying disease process, and maybe behind that pathology is going to be why did that abnormality occur? And linked to that is going to be incidence, perhaps transmission, particularly with regard to congenital malformations. It's going to be genetic, maybe infectious, maybe lifestyle toxins, all of those things. One would also need within the discussion, and I think this is going to become relevant in your exam, is your examiner is going to say, well, what's going to happen? What's going to happen next time round for following children? And what's going to happen with this child or with you in terms of, if we just leave this alone, where you're going to go? Also important both for your patient and for the exam is what is the associated pathology. And this becomes important, for example, today. Michael, we're in theatre, we're doing a scoliosis. The scoliosis itself is fairly straightforward. It's a lengthening rod, and it's a matter of unscrewing some bits and rescrewing other bits, and in the middle making things longer. But importantly behind that is the fact that our child is neuromuscular, that there are anesthetic associations, and in terms of Rob Dunn's patient, there's the important aspect that the associated pathology impacts on longevity. This child is not going to live forever, and that alters our management, which then brings us to natural history and prognosis, both globally and in terms of what your presenting complaint is. How is this going to affect the patient? So I don't want to get mired down here. And here's the sort of short bit is, I don't know what happened there. In terms of the pathology that we have, sorry, I'm a little bit stuck here and I'm not sure how to get out of this. Okay, that's better. So just give me a moment. So we went on a prognosis treatment, and with classifications possibly leads on maybe to research. So in terms of what do you need to know from this particular patient, those three things are going to come into play. What you also need to know is an approach to treatment. And I've said this before. If you think in terms of hierarchies, potentially you want to know what are your goals? And those goals, more or less, and I've said this once again before, is the goals should more or less be universal. Behind the goals are going to be principles, and those principles may change slowly over time. And then from person to person, possibly unit to unit, are going to be strategies. So you're going to use internal fixation, external fixation, or you're going to be conservative, or you're going to be aggressive. Those strategies may well change, but the goals should stay the same. Once again, within the scope of particularly your clinical exam are going to be the controversies. What are the arguments for and against a particular method of treatment? And lastly, a discussion about where you're going to go with your treatment plan. So all of that's a little bit of a blurb and a background. Here's a patient. There's obviously upper and lower limb malformations. So then just generally, Michael, I'm going to put you on the spot here. Where are you going to go with this? A lot of the time with the exams is we're going to give you a picture. What are you going to do with this picture? Michael, let's run with it a bit.
So first things first, I want to look at the child head to toe to see if I can find any other signs of dysmorphism. The global picture is more associated with post-axial deformities, whereas pre-axial deformities are generally in isolation. I can't really tell here if it's a pre or post-axial deformity. I'd like to look at this feet a little bit more, but I can't see any other obvious dysmorphism in the face. I don't know what's on his forehead, however.
Yeah, it's a drip.
Oh, it's
so
a
it's
drip.
just it's a drip. Yeah, I know. Looks a little bit strange. Just tell us. I'm confused. What's a pre and post-axial deformity?
So pre-axial deformity of the upper limbs is the outer side, so the radial side, so the thumb and the index finger, and on the lower limbs it's on the inside, so also the hallux, whereas the post-axial deformity is on the upper limb is on the inside, and on the outside on the lower limb.
Okay, great. So just bear that in mind for a little bit later, and we'll go through why that would be the embryology, the rotation. So here we've got a upper and lower limb deformities. The face of the child kind of looks more or less okay. So we talk about dysmorphism. The trunk looks relatively normal in terms of proportion with regard to the head. So there's a limb thing. Bear that in mind. And remember, we'll talk a little bit about it. Limbs also at times go with internal organs, go with facial abnormalities, go with syndromes. So just, and we're going to go through this in a little bit of detail now. Now we've got a clinical photograph of me holding onto a foot. And I think it's worth slowing down a little bit here now. And I'm just checking the senior guys. Nico, you here. So Nico, what do you see?
Yes. So it looks like, just like with the previous picture, it looks like there's probably a failure formation of some sort.
Yeah.
And in this case, the lower limb, it looks like there's lateral absence. So lateral ray, lateral sided absence.
So don't Nico, slow down a little bit. Don't jump straight in. Where's the position of the foot?
So the foot is in varus.
Okay, so it's fallen medially, eh?
Yeah.
Look for dimples.
Sorry.
So the foot has gone. Just stay with what you've got and interpret a little bit later. The foot's gone medially. Are there dimples anyway?
Probably on the inside. I can't see the inside, but I suspect there will probably be.
Yeah.
And difficult in this young child to see a bow, but
yes,
I expect there would be.
Okay. So difficult, and particularly with this photograph, to see a bow. And then what you should be able to see from this picture, which is more or less lateral, is there a knee profile? And what I'm particularly interested in now is where is this tibia sitting in relation to the knee joint itself?
Yeah. Well, it looks like it's posteriorly
posteriorly subluxed or sagged, yeah. Okay. So put this in as clinically a tibial aplasia for those reasons. There's the gap in the tibia. Look, I think that it would be a bit of a stretch to be able to say definitively without x-rays, etc., that this is what it is. But you've got softish indications that we're dealing with a tibial aplasia. And I think from an examiner's point of view over a Zoom meeting, those are the sort of things that I want you to be talking about. So where's the foot, where are the dimples, if any? I think that personally, if I zoomed in over here, over the malleolus, maybe there's going to be dimples. I'm not sure. I don't think it matters. I'm not going to stick there. But I do think all of these are soft things, and it becomes, and I acknowledge this, and we all do, is that it's a bit more of a difficult game to be playing, given the fact that usually you've actually got a prop in front of you. You can pick it up and examine it, and now all you've got is a very flat 2D photograph. So I get you. So let's give it a tibial aplasia. I'm going to rush you straight into a traditional classification, and you immediately, Barry, are you here? I don't see Niku.
Yeah,
Okay, so just, you're going to tell me you've got a different classification, and I'm quite happy with that. What classification are you going to use for a tibial aplasia? Or are you going to use the same one?
I'll use the same one.
Okay, how does it work? Just tell me again.
It's which part of the, so whether there's a physis or not, epiphysis, a proximal epiphysis, and which part of the diaphysis is absent, I think.
Okay. So you should be able to see it on your slide there. This is from Jones's little sketches. There's a 1A and a B. And it goes from really bad to good. Just followed at the top here. Do you agree with me?
Yeah.
What I found interesting is the 1A is the total absence of the tibia. So that's really bad. Then it goes to the 1B, where actually there's a little nubbin, an Anlag, and we can talk about the word. Who's going to be German for the evening? Who gets to be the German person? You're going to have to nominate somebody, Barry. You are
Sharonga can be the German person.
Okay, so Sharonga is now nominated. Sharonga, you invisibly are going to sit and look up Anlagen, the German, and what it means. There, I can see you on Google. Fine. There's an Anlag, an enlarge over here in the type 1B. And in the type 2, there is now proximal tibia, and it's going to have impact later. And then, funnily enough, the type 3, which should be now getting better and better, actually kind of get worse. Because you don't have a useful proximal tibia. You agree with me, Barry?
Yeah.
But you do have a distal section. I can't recall having seen one of these. And then the type 4 is what we speak about, the rotatory type, where there's splaying of the distal tibia and fibula, but there should hopefully be an intact ankle joint. So that's the easiest to deal with. Now, I propose, Sharonga, you back it with the definition of an enlarge. You're going to have to amp up your internet access to Google. So an enlarge is going to be an architectural precursor. And so in the 1B, you do have a precursor to what is going to follow. The reason that I'm a little bit...
Stuart, can I just ask a question? Can you see straight from birth whether it's a 1A or 1B, or do you have to wait to see if the proximal tibia ossifies?
Yeah, so probably...
because it would have prognostic implications if you made the diagnosis early. Is it a certain age group where you say You rather wait till they get to a year before you classify them as a 1A or 1B or a 2.
So let's just hold it there. So certainly our experience in the PFFD and MRI shows us that the on-log, the 1B, will later become radiologically evident on X-rays, but is invisible at birth. Does that make sense?
Yeah.
So according to this classification, if you just waited long enough, that proximal tibia is going to become apparent. So when I look at the Jones classification, what's important to me, and it's important here, is do we have an intact extensor mechanism? Now, I take that to mean that you've got quads, a quads insertion, a patella tendon, and a proximal tibia to insert to. And I think that just practically, that makes a difference, because if you've got an intact extensor mechanism, so call it, for want of a better term, a Dix-Peek A or 1, that would then include the type 4, the type 2, and probably the 1B.
Yeah.
Does that make sense so far?
Yeah.
And I think that that's probably evident, certainly clinically, within the first year of life. And that starts to provide you a template for how we're going to treat this. Because if you do then have an intact extensor mechanism, then most of us would agree that you need to be reconstructing an intact baloney or a baloney type amputation, or include the foot if you've got a viable foot and ankle platform. Whereas if you've got an entirely deficient extensor mechanism, then you have an unstable knee. And there are those people who would, Jones, transfer the fibula into the notch, but you run the risk then of having an unstable knee mechanism. You need to bear that in mind. And I think most authors at this stage would be then saying, go for a 3-knee amputation, just make things simpler. So to me, that's the crux of what you're dealing with. And so learn a classification because it's a talking point, but be able to criticize it for what it is. And I'm sure by now, Joel Paley's come up with a 14 type classification system with subgroups in each category, which is also unworkable. I think simplistically, I would like to see something that you could work with that would guide management. And bear in mind that all of this is going to be a conversation with a parent one day. And so when you first meet this parent, you probably are either in a nursery or postpartum week 3. You don't need to know right now, but you need to know enough to be able to say, we have a plan that we're not going to decide quickly, but the plan might include reconstruction, or it might include, and be positive about the concept, it might include a reconstructive amputation, because that's what they are. And then leave the details and let that start to the conversation, then guide you later to be able to say, probably around about the age of a year, now we're in a position to make a more thorough evaluation. And in your tibial aplasia, you are either going to have an amputation through knee or below knee. Just practically, Nico, if let's assume that you're not doing, for whatever reason, that you are going for some sort of below knee amputation. So I'm talking classically the type 2 here. Let's assume that it's not a type 4 with an intact foot, that you've decided to reconstruct foot ankle platform, that you're going for an amputation, a below knee amputation. Just guide us through the process of what are you going to do.
So how will I do the below knee amputation?
Yeah, just practically. What type of below knee? What are your goals? Are you just going to go straight below knee? Are you going to, yeah?
We want to preserve as much length as possible because we know it will impact on energy consumption.
Correct.
So the more distal you can do the amputation, the better.
Yeah.
That that being said, there's really no difference between a low below knee and a medium, below knee. The distance doesn't really matter. When I talk about distal amputation, I'm thinking about SIMES type of amputation. So that will probably be the best.
SIMES will be the best. Why? Why would you prefer a SIMES to a usual below knee junction, mid, and proximal third?
Because SIMES, you still have a stable platform to weight bear on, where with below knee, you're going to need a prosthesis. Okay.
So I think it's important just to realize that, remember that your orthotist is not going to like the SIMES. You will. I like a SIMES because I think it's hardworking, it's dependable, you've got a sensate flap, and you can get out of bed at 2 o'clock in the morning, either if you're old like myself and Steve Roche, to go to the toilet, or if you're young and have just had your baby and getting up to breastfeed. So now we've covered all of those bases. You don't need to jump. Exactly. Oh, yeah. Okay. So let's stay clear of finding guns under your pillow. Let's keep it tidy right now, but you get the point. You don't need to go find your prosthesis to walk around. Your SIMES allows you to just get out of bed. The orthotist, by the way, doesn't like it because he or she would prefer to have a length that will allow to accommodate for a both ankle and heel, so a SACH type implant, type prosthesis. So just be aware those conflicts. The standard is going to be a SIMES. How do you do the SIMES, by the way? Just practically. You've got a tibia. You bring the arm. I'm just going to jump in. Yeah, you there, Nico?
Yeah, sorry. So you're going to have to do a synostosis of your tibia and fibula.
Correct.
And then place your heel pad underneath the foot.
Okay. So, and I think, Pravesh, I'm going to make you in charge of just checking that nobody's writing in little questions and alert me by SMS, by WhatsApp. This now, Ayik, I saw you here earlier. Ayik, just now start with describing what do you see, where's the knee, where's the foot and ankle, are there dimples, same story.
So, can you hear me? Because
I can hear you perfectly.
So, what I can see here, the dimple I can see it anteriorly.
Mm-hmm.
And I anterior. Well,
so you're breaking up a little bit.
Yeah, maybe network is not good here.
Okay.
I hearing myself at the same time. I don't know.
So it might be you've got two devices that are now feeding back to each other.
I got one device.
Okay. So just, which way is the foot going?
So the foot here, it looks like it is going medially.
Medially or laterally?
Going laterally.
Going laterally. And are there a normal amount of toes?
It looks like there is only 4 toes.
Correct. If you had to hazard a guess, what would be your diagnosis and what are the associated abnormalities you would look for?
So here I can see like there is a deficiency of big toe. So if I would guess, I would say that there is a tibial deficiency.
Okay, so Aik, given the fact that you...
Yeah.
Given the fact that your foot is going laterally and that there are absent lateral toes rather than absent
Medial side.
axial, yeah.
So I would say here, if it is like that, so the deficiency here would be fibula, would be the lateral ray. So deficiency of the lateral ray will continuous with the fibula deficiency.
Okay, and the association of your Fibula Hemimelia?
Yeah, is the lateral ray deficiency.
Yes, lateral ray deficiencies, tarsal coalitions, Fibula Hemimelia, anything else?
I can't remember anything.
So this is the group that goes hand in hand with your proximal femoral focal deficiency. Okay. Yes. So it's that, usually that cluster. And this, in fact, is a Fibula Hemimelia. Just be looking for those. So in your head, try and cluster and group the abnormalities together. It's not going to give you the diagnosis, but it's going to give you softer signs towards a diagnosis. And I think that's the important thing at this stage. So remember that your Fibula Hemimelia, and I've got them here, proximal femoral focal deficiency, the potentially within that group is going to be the coxibara, short femurs associated, and the absent tarsal bones raise tarsal coalition. Now I've got what to my mind is a fairly useless classification, but you know what, it is what it is. So partial and complete. In my head, and I do think once again, you probably need some or other classification system. I don't really mind, but it's going to be a starting point. By the time you have a starting point, you need to be discussing what are you going to do. And I think that so far as I'm concerned, there are going to be two biggish groups, that with a stable ankle mortise and a foot, and then the unstable mortise and an abnormal foot. And I think once again, if there is not a stable mortise and a normal foot, one's heading towards a Symes amputation. And I think that in general is going to be the consensus opinion for this. So I think in fact, then just off the top of your head, and it's not part of this talk, but the other, what we call kyphosis of the foot, Santa Marie, I thought I saw you earlier. Any idea what this is? Once again, a relatively poor photograph. What have you got?
I'm here, boss. Can you hear me?
Yes, hear you beautifully.
Okay, cool. Yeah, I can see the sole of the foot is basically parallel to the leg.
Yes.
So I would think that there's absence of the ankle joint.
So it's going to be another kyphosis of the tib and fibula. So we've dealt with the Tibial Aplasia, Fibula Hemimelia. There are going to be two more coming up. They cluster them together. By the way,
one I can think of is CPT now.
Yeah, and that's coming next. So the last one.
But I was going to say, this isn't CPT.
Not CPT.
I'm not sure what this is, but.
So then go backwards and just say which way is the apex of the bow? Is it posterior, anterior?
Almost looks like it's an anterior medial.
Apex of the bow. Apex is behind, so it's posterior.
It's posterior medial.
Posterior medials.
Apex of the tibia. With
yeah.
Complete, eversion of the foot to the lateral side.
Any handle on what this is, where it goes, what we do with it? What are you going to suggest at birth? So this is.
I would suggest amputation.
Oh, no. Go backwards, go backwards. So this is the so-called packaging defect. This is the one that grows of its own accord straight. It is not associated with pseudothroses. It will self-limit. It's going to get better. I had a very involved some time ago radiologist and his daughter. It gets better. It was initially called, by the way, a CPT because his radiologist, he got an antenatal scan. There was a whole hoodint about this. It gets better by itself. It does leave a residual leg length deficiency. So you've got to watch it and think about lengthening stroke epiphysiodesis. And then, Sante, this is the one you were looking for, the last one of the whole group. Position of your kyphosis here, anterior, posterior.
It will be anterior lateral bowing of your tibia.
Anterolateral bow. So this you now know what's the cluster here. Because once I show you this picture, this just opens up a little drop box that says to you what?
So this is your congenital pseudoarthrosis of your tibia.
CPT, and now you're going to look for what syndromes, what global picture.
It's usually associated, this one, with neurofibromatosis type 1.
NF1, correct. And then your criteria for NF1 are going to be?
More than 5, cafe lay spots. Look for bilateral acoustic neuromas.
No, that's NF2.
Oh, that's 2. Sorry, that's 2.
Yeah. Get Big Red out of the back cupboard. No? Shall I leave Big Red in the back cupboard? So cafe low spots, I agree. In my head, and Big Red will be more on top of this. In my head, you're going to have three skin. Big Red, is that right?
Yes.
So 3 skin. Cafe lay.
Axillary freckling.
Axillary freckling and?
The neurofibromas.
Cutaneous neurofibromas. Then I've got 2 eyes.
Yes.
Yeah, what are they?
Least nodules.
Yeah.
And hematomas. Well, the least nodules are the hematomas, optic gliomas.
They are the hematomas, optic gliomas, yeah.
And one
family, yeah, got it. All right, now, Michael, you are the guide here. We're back to here. Are we going to go through the background embryology, or do we want to go to questions, or do we do questions before and after? We got time. Michael, comments?
Yeah, probably continue with questions at the end, sure.
Okay, let's do that. So the embryology is kind of just background, and I think that there's certain concepts that I want to get across. I think that all of this is non-core knowledge, but hopefully if you get an idea of the pathways, and it's only going to be in very general terms, hopefully that guides us as to why certain embryological malformations occur in clusters, in patterns. So the first concept, and by the way this is now discredited, but some time ago there was a concept that ontogeny recapitulates phylogeny. In other words, your development mimics almost an evolutionary process. So basically, everybody have a look at the bottom here. Every human embryo goes through this process. Fish, salamander, tortoise, chick, dog. Is that dog? Calf? Doesn't know. Doesn't really matter. But I think that what is important is that this theory is discredited. I get it. But there are certain aspects of it that perhaps are useful and worth bearing in mind. That's just sort of the same thing, but to remind ourselves that that there are certain processes, for example, segmentation, that we see in this photograph, that are not unique to humans in terms of spinal, for example, or thoracic development, but are also something that worms go through. Then there's a concept that there is within embryology homology among species, and so that certain parts, and let's get the concept of building blocks. Certain building blocks of limbs would be very similar between very different species, and we'll see that in more detail in a moment. And then just very briefly, your normal fetal development. Now, for those of the many registrars now having children, bear in mind that embryologically there are really two big time periods. Up until the end of the first trimester is really organogenesis. So in the first trimester, you're going to get implantation of a zygote. You're going to then get a disc. That disc is going to gastrulate, forming endoderm, mesoderm, and ectoderm. And now just stop there a moment and remember that in pediatric oncology, we generally deal with mesodermal structures. We get sarcomas. Your endoderm, ectoderm are eventually in oncology end up in carcinomas, which are not the usual in pediatrics. And the biological activity of those two groups is linked to the embryological cell lines, and they behave differently. So it's just a concept that comes out in a very different group of orthopedics at a later stage. At the same time, just after gastrulation is neurulation, so you have an anterior folding to get a gut, basically, and a posterior folding to get your neural tube, which also becomes important because, for example, when we see myelomeningocele, that is often associated, for example, with hydrocephalus. That neurulation process probably has an insult that affects two different processes, and you get almost this double hit of pathology. By the end of your first trimester, you should have organs in place, and from there on, really, you are maturing. You're maturing in size and you're maturing in complexity, but the basic imprint has been made. So just stop me at any point if you want me to go slower or faster. Pravesh, you're going to have to find the speed up, slow down buttons. What do we need to know here? Remember that just basically all of your cells genetically are usually identical. I know, Nico, you're going to jump in and talk about chimeras and mosaicism, but most of us have the same genetic imprint in all of our cells, but phenotypically we differentiate. Now, remember that certain cells, myofibroblasts, for example, may be pluripotent in terms of what they can differentiate into, so they can become fibroblasts, or in fact transpose and become bone progenitor cells. But generally, by the time you've decided that you're going to be a muscle cell, that's where you stay. In terms of how your limbs and organs are formed is both time dependent and site dependent, and that's the message of this spatial and temporal interpretation. Depending on where your cell ends up at what point in development will, through signaling, tell it what type of a cell it's going to end up as. And then this whole concept of genetic conservatism and echoes that you might have homolog genes that would have very similar codes between fruit flies, fish, and ourselves. And so this is just a slide to show that the essential building blocks between the groups are the same. I don't think that this is that important. The concept that we might share homolog genes might be. That signaling, although it ends up in a different shape, is probably the same type of signaling that occurs in different species. Okay, so we got it. We got cells that are all the same, but their genes are different. And those genes imprint on the cells depending on position and time as to what they're going to end up as. So far, so good. The process of limb axis starts with initiation. That's a limb bud. The tip is going to be an apical epidermal ridge. The dorsoventral axis is going to be in front, and so that is going to be from dorsal behind to ventral in front. The AP gets us a little bit stuck because the AP axis actually talks about a zone of polarizing activity, which, so let's slow all of that down. Let's just say that your thumb and your hands come straight out as a bud. The thumb being, let's make it superior, which is terminology that we all refer to. The thumb is going to be before the axis and make the axis of your limb bud the middle finger. Things in front of that limb bud are going to be preaxial. So thumb and big toe preaxial. The axis is the middle finger, middle toe, and postaxial is going to be little toe, including things like fibula or ulna. So I'm going to work through these. Here's an apical epidermal ridge. At day 28, it's pushing out. You will now have axes. And when embryologically we say anterior, we talk orthopedically about superior and inferior. I don't think that the details are important. I think what's important is to realize that there are gradient zones that will determine that, for example, you form a thumb along with a radius, or that you form lesser fingers along with an ulna. And that if certain processes go awry along the way, that clusters will occur. For example, that you would get radial abnormalities in conjunction with thumb abnormalities. So I'm going to just touch on here that for your segments, you're going to signal in your upper limb, for example, in a cluster for scapular, humerus, radius, ulna, metacarpals, and digits. So that's longitudinally, and at the same time, that in your zone of polarizing activity, you're going to have gradients that are going to signal for thumb and then lesser fingers, radius, and ulna. And I'm going to kind of leave it there. And then in the same way as you would go superior, inferior, or preaxial, postaxial, you would also have signaling that would tell the cells that they're going to become palmar without hair, for example, or dorsal, and the palmar is going to be thick skin, versus dorsal skin, which is thinner, it does have hair, very similar to your foot, where the dorsal, your superior aspect of the foot is going to have hair. The tough, thick, specialized skin on the sole of the foot is going to be hairless. So they're analogs of each other, as is the thumb and the big toe. Both finger, toe, and joint formation, Michael will tell us, is from apoptosis, creating clefts over here. And that if you don't have the apoptosis, the programmed cell death, you will have failure of differentiation, either of joints, for example, tarsal coalitions, or fingers with your syndactyles. And there's this question of rotation, and Michael started talking about this, that you would have external rotation, placing your thumb lateral, and that's in the upper limb, whereas the opposite occurs in the lower limb. You have internal rotation, placing the hallux, your big toe, medial. And that just explains a little bit about why your preaxial hand, lateral, preaxial foot, medial. So the clinical implications of this is that in terms of deformities, and here is your Swanson classification now: failure, formation, differentiation, and segmentation, duplication, overgrowth, undergrowth. I always remind you that the one that all of the registrars leave out is constriction bands, and then I myself am the one who always leaves out the very last one, which is generalized anomalies and syndromes. But I think that if you remember 3/4 of this slide, it's a good starting point to be able to discuss in very general terms any clinical embryological abnormality or congenital. Remember that embryological would refer to something that occurs as an embryological process. Congenital is anything that is present at birth. So you've got failures of formation, and the only thing I really wanted to point out here is that if you have a transverse arrest, and bearing in mind 3 slides ago I said that the segments, scapula, humerus, forearm, carpus, and hand are elements that are coded for, that you might have one of those that has a transverse arrest. And the classic transverse arrests, and hopefully at some point I'm going to show you examples of a transverse arrest, whereas longitudinal arrests are either radial or fibula, tibia, radial would go with tibia, and ulna would go with fibula. Those are longitudinal arrests. So transverse is one segment, longitudinal will be one part of the segment. These are names, and I'm going to actually, I think, skip over the names, except for Amelia is an absence. Mero is absence of a part. I think for the rest of it, we went over this last Friday. Ectrodactyly is a cleft or a lobster claw type. We're losing the middle part. And here we have an example of a transverse arrest. Clinically, probably you've left behind at least fingers and carpus. There might be some annulage of a forearm, perhaps a humerus, and maybe a scapula in there. But by and large, there is a transverse arrest presence in these hands. And I'm assuming that somewhere here on the left-hand side, there is a thumb present. Certainly there's a thumb on the right. So that's a transverse arrest. A longitudinal arrest will lead to what we've discussed this evening, the Tibial Aplasia, Fibula Hemimelia groups. Failure of differentiation. So if you have a failure, for example, of differentiation of joints, you're going to end up with arthrogryposis. If you fail to differentiate between fingers, you will end up with syndactyles. If there is differentiation between radius and ulna down here, you will have radial ulnar, for example, synostosis. So the failure to separate differentiation will form that group. We're going to leave behind that. And so here we have a failure. What is this, Nico? Any idea? Clinical photograph. Springle shoulder. What failure of differentiation is there here in the Sprengel?
So there's a homovertebral body there.
Yeah,
so it
correct.
does not have tips.
Correct. So your homovertebral bar is a failure of the separation, really, of the scapula from its origin in the cervical region. And on the right-hand side picture, obviously a syndactyly, a complete syndactyly there. Then we get duplications. So you can have whole limb duplications. They're sort of the weird things. Mirror hands, very, very rare. This is one of our patients, a duplication, a partial duplications of digits here with deletions. Certainly the hands over here. You are seeing fingers but no thumbs. So you've got post-axial duplications probably. Although maybe you could argue that there are duplications there of thumbs. Just quickly as a trick, Berry, how are you going to differentiate radiologically between thumbs and big toes and lesser fingers?
I think the easiest way is probably to see where the fasces is on the metatarsal.
Yes. So
where
and your big toe, where is it?
It's distal, and the lesser toe is proximal. Yeah.
So your lesser toes on the metatarsus is distal, the other way around.
Oh, sorry. Okay.
Got it. Yeah. And exactly the same for your thumb, hey? And then the phalanges, obviously, what's important?
Oh, well, the number, I think.
Number, yeah. Got it, yeah. So two in the thumb, two in the big toe. Okay. Overgrowth, classically here associated. Ayik, what gives you single toe, big toe overgrowth?
So we do have a neurofibromatosis is one of them.
Correct, yeah. And then there's a cousin of neurofibromatosis. Do you know a name?
I try to
Peter Fenter, I see you here. A weird syndrome that takes many forms. Nico, you're going to come in from left field here.
I have no idea.
No, man, the shape, the original Greek shapeshifter who assumes many forms, can see past, present, and future. Proteus, well done. Okay, so Proteus, classically overgrowth over single digits or hemihypertrophy and other weird manifestations. Proteus often looks syndromic, funny faces, weird stuff happening. Okay, undergrowth, your brachysyndactyles and brachydactyles. Constriction bands, this is one that I remind you guys that you always forget. And then there's going to be the mixed group after that. The generalized anomalies and syndromes. Now, I think that often this is going to come up. This, Nico, who's the last person that's with you? So it's you.
My dear friend Yapi, that doesn't want to be nominated.
Where's Yapi?
He's there.
Is it there, Yapi? Come. What have we got here? It's a tiny photograph, and I'll forgive you for not getting everything, but what are we looking at here?
Well, it looks like a left hand of a right hand of a child, boss.
Yes.
There's a deformity in his forearm. I'm not so sure what it is. I'll just get in a better picture, but from this view, it looks like he's got a relatively stable elbow. He's got 5 fingers. The thumb looks abnormal.
Four fingers,
yeah,
eh?
4 fingers plus whose thumb is that?
That's his thumb, and it's
Yeah.
I don't know if it is mine, but my finger behind there. So there's 4 fingers and 1 funny looking thumb, and then the examiner's thumb behind it, I think.
Yes.
Okay. Which is there a kyphus? Is there an angular deformity of the forearm wrist complex.
It does look like there is some post-calf. Yeah, I would say.
Okay, and which way does it fall? Radial or ulnar?
It looks radial. So it can either be radial club hand,
Yeah, or
hypoplastic thumb.
Are they related?
Yeah, I don't think so.
Yeah, so they almost always go together. Eh? So remember, so this you can see, it looks like there's a deficiency of the radius here. And your radial club hand almost invariably, not always, but almost invariably goes with some form of hypoplastic stroke deficient thumb abnormality. Now, there's a kind of hidden rule with upper limb versus lower limb abnormalities. In general, the congenital abnormalities of the lower limb are standalone. They go by themselves. But the upper limb, because your upper limb forms about a week earlier in the first trimester, often goes hand in hand with organogenesis. So radial club hands classically go with, let's call it whole body clusters of disease. You're going to come up with, Yapi, you get to go first. You're going to come up with one.
So they come up with, they present with a Vactral group.
Vactrals, okay, go for the easy money. Nico, next.
Thrombocytopenia,
Absent radius. Yeah.
Fanconi's.
Fanconi's, oh, it is. Okay, Yapi showing off now. Anything else anyone want to add in? Haltorum. Haltorum, yeah, got it. And then I've got TAR syndrome. But in fact, we've had TAR. So that's, I get stuck there. Anybody else got anything else? There's probably more. I'm happy with that. Okay. Bear in mind, though, that once you see radial club hand, look for other things. Once you see upper limbs, look for other things. And who's doing spines at the moment? Ayik. Ayik, you spines?
Yes.
So when you see a congenital abnormality of a spine, what is the chance that there's something else going on, and where do you look?
So the chance there is, I would look down, see, because the other chances that there might be problems on the lower limbs, and on the upper limbs, like to us now the pharyngeal shoulder, and in the
Okay. Yeah, so upper limbs, yes. No, I don't like lower limbs. What lower limb abnormalities are you going to get with spine commonly?
So we might have the club foot.
Okay. All right, I'll go maybe. Yeah. Okay, I'll grant you that. What non-orthopedic problems are you going to get with a congenital abnormality of the spine?
So there might be just problem.
Yeah, what? Which problem? What are you going to screen for? Peter, you were around. Dr. Fencer, you back?
Yep.
Okay, tell us. You in your clinic, you picked up the, I see beyond us here. But Peter, you're up. You get a congenital abnormality of the spine. What are you going to ask? You? The child looks otherwise well. What are you going to miss if you don't look for it?
Neurofibromatosis?
No, man, you've got like a little butterfly vertebra, a little like hemivertebra.
Neural defects.
Okay, look for the neural tube defects. They're relatively uncommon, but they do occur. What's going to occur with regularity? Niku, come on, help us. Yeah, so neural tube defect, spinal dysraphism, yeah, come, abdominal abnormalities.
Kidney problems?
Kidney. What rate? Yes, absolutely. What percentage?
I think it's like 50.
I've got 30%, but I'll go with 50, yeah. So So you are, and normally it's non-important. So they're horseshoe kidneys or transposition kidneys, they're weird, but you need to have a look for them, okay? So I think you're quite right. Look for your springal stroke clipple file group. Look for the club feet, yes. Your neural tube defects are usually going to be clear, and then look intra-abdominally for kidneys, okay? So we're still with generalized abnormalities. I've got, very quickly, I'm going to tell you, not ask you. We've got a PFFD. Look for then the Fibula Hemimelia. I didn't have anything else with this child, so I'm not sure why I put her in. Maybe it's a gratuitous shot of Dr. Mears in the background looking slightly confused. Yes, no. Radial we've dealt with, vectoral, radial compound, halterum, Fanconi's, we've got all of those. Yapi, you're happy with this small baby radial deficiency and the absent thumb? Yapi?
Yes. Yes, boss.
Cool. Your tibial syndromes, okay, got all of that. So that was where that group ended. And I don't think, and I need to stress this, I think that the background information is important, but the actual detail, I don't think for our purposes is important here. So now I'm going to take you, jumping backwards and forwards, to the questions. And I wanted to say this, just to have a look at, is here to me is where we all should have started, is an MCQ. Everyone familiar with the format? We've got the little lead question. A 6-year-old boy has got a leg length discrepancy. Read the question, guys. The affected side has a short leg. Be careful here. The as designated linguist now, Berry, a leg is what?
The portion between your ankle and your knee.
Correct, yeah. So that's a leg, hey? So that's a leg. When we want to say thigh, we're going to say thigh. And when we say lower limb, we say that. Go. So you've got a short leg with a medially deviated foot. So there's something going on here, either tibia or fibula. But given the fact that it's medially deviated, Kirsty, what are we thinking?
Anterolateral bowing, neurofibromatosis.
Okay, or straight lateral bow, which is going to be tibial aplasia, huh?
Yes, yeah, sorry, either of them.
And we've got an apex, tells you now apex lateral, so probably tibial aplasia. The following are true or false. Now be careful, because this is a straight MCQ, and it's going to have told you in the blurb at the beginning that one or more may be correct, and you may or may not have positive or negative marking. You get how it's going to go. Now, and I spoke to Michael about this a little bit earlier today, but if there are, I've spelt it badly, but there are multiple cafe spots. If there are also multiple cafe spots, then a diagnosis of NF1 is likely. Now, you know what? Sorry, let me just go back. Given the fact that I've given you a clinical scenario, you've also got this sort of post-lead statement. So you've got a short leg and the cafe spots. I don't know. Maybe NF with bury your maybe the deviated foot. Yeah. So let's maybe make that right. A medial physeal arrest due to trauma is impossible. Now, none of us really need to know anything except the fact that in medicine, nobody's going to mark impossible right. You agree?
Yes.
Fine.
False.
Macrodactyly and dysmorphic features would indicate Proteus. Well, yes, actually you could do. Yeah. So you've got a weird thing and now you've got more weird things. So it could be right. 3. Maybe. A predicted leg length discrepancy of centimeters would be an indication for lengthening if the foot is normal. Does sound pretty right to me. Yeah?
Yeah.
And a lack of an extensor mechanism would be an indication for a 3-knee amputation. So So actually, the one that's going to be wrong is the medial phalangeal rest due to trauma is impossible. Definitely, it's got to be wrong. Macrodactyl with small features indicate proteus. You know what? So actually, we've only got one wrong. I think the point I'm trying to make is that you might not know all of the detail here, but given the fact that certain rules about maybe likely impossible are going to say, well, you know, those things could be right. Now we get here, and this all now changes. Single best answer, number 1. 4-year-old boy, isolated deformity of the lower limb. Read all of it carefully, because there's not just the facts, there's implications. There's shortening of 20% with respect to the normal side and an absolute difference of 5 centimeters. Nico, you following so far?
I am.
Foot displaced medially, this leg subluxes posteriorly. And when I say the leg subluxes, I'd probably come back and revise it, say the knee. So what have we got so far, Niku? What's the relevance? What is your interpretation? What's the context?
So first here with the leg it's shortening 20%, and we're at that border where we will struggle to do lengthening or stage lengthening.
Yeah, okay. So we're at the boundaries, get it? And I've done that purposefully. Then I say the foot's gone medially and the leg subluxes posteriorly. What am I trying to tell you? What's A, diagnosis, B, implication on diagnosis?
So that we are concerned about stability here.
Yeah.
So that will direct us into a specific management algorithm.
Okay. So you can see I'm trying to tell you that there is probably a tibial aplasia, that we borderline lengthenable, and at the same time that you are unstable. So we're thinking that we're not even going to do anything. Muscle bulk appears normal. I throw that in only to tell you that this is going to be an embryological deformity, not neuromuscular, I think. With regards to management, the following is most correct. Now, here I've got the Paley multiplier for a boy, 4 years old, and I'm showing you here with my pointer is correct. The expected discrepancy is a multiplier of 2, 5 centimeters is 10. You get it? Yeah? Lengthening should be undertaken. Well, we kind of maybe would. I agree with you. Should we though? So if it was isolated to this cluster, then actually, if it was just about a leg length discrepancy, it's right. You agree, Nick?
Yes.
Fine. So put that in the back of your head, but it's a borderline correct. It's correct.
Could I say if the knee is deficient that I wouldn't lengthen? Therefore,
yeah, exactly. Yeah. Well, it is correct, except for some parts of it are incorrect. So other congenital abnormalities relatively rare, and the deformities may be addressed in isolation. You know, I'm looking at that, and what does that mean? Well, it means that you probably have got a tibial aplasia, so you can address it by itself. So it's kind of correct, but not really strongly correct, once again. Stability of the foot determines the type of reconstruction to be performed. Well, it would be appropriate if this was just about the foot. So kind of also partially correct, but it's going to swing us. And so who was it that jumped in there? Was it Michael? So the active knee extension is an indication for a Symes. Well, is that correct? Niku?
No.
No, because I've told you already that it's leg subluxing posteriorly. So active knee extension is an indication for a Symes, but not in this case. You get it? And in fact, now, knee joint may be recreated or repositioned. So having looked at all of this, I would actually have to come back. Obviously, it was late last night when I did it, because I don't have one single answer here that I would give as the best possible. I would want to have something that we're all going to agree on. And in fact, looking at this now, Nico, I don't have something that I think that all of us are going to say is the best possible. Do you? So anything jump out at you?
Well, the most right answer probably is number 2.
Number 2, other congenitals relatively okay. So I would leave it there. Bear in mind though that having left that as quite a soft endpoint, that you're going to see that the guys in the top 10, they're going to be scattered, and they're not all going to home in on this one right answer. It's going to make this look like a bad question, and it probably is. All right. Can you see how the whole thing is structured? And it's quite complex, and I think it requires a special skill to put it together well. It needs to be reevaluated, probably needs to be tested like I'm doing now. So SPA 2, I'd go back and correct that, by the way. SPA 2, newborn girl, bilaterally, laterally displaced feet, bilateral, hey? Absent lateral raise. I'm giving you all of the indications, medial biokyphus, that this is a Fibula Hemimelia. Legs are short by 3 centimeters, so not too bad, but it's a newborn, hey? The following SPA. Post-axial deformities are associated with PFFD. Yes, no, Niku?
Yes.
Yes. Reconstruction of the bone will correct some, but not all of the leg length discrepancies. Yes, no? Yeah. You agree?
Yes.
If you correct the bowing, you're going to get length back. Multiply for a newborn girl is 3. I looked it up. It's 297 or something. And you're going to get a discrepancy of 6 centimeters. So that looks about right. So bilateral, and I have a look at it. Excellent function. Does it jump out, Niku?
Definitely not.
Doesn't. Okay, so put that in the back of your head. Multiple reconstructive procedures are associated with poor outcomes.
That is true.
So they're all true, by the way. So which one are we going to choose? And unfortunately, I haven't built in, and I'm going to do it with time, an online vote. But just all of you put down what you think are going to be relevant here. Look at it again. I'm going to put Nico, you on the spot here, and just say which you're going to go with, followed by you, Kirsty, the Ayik. You're going to have to choose 1, 2, 3, 4, 5 as the best answer. We're going to let everybody else off the hook, and me.
Should I do it now? Or?
Yeah, do it now. Just tell me. Just tell us. Shout it out. So start with you, Ayik.
Yeah, number 2. I would.
You're going to go number 2.
Yes.
Okay. Yeah. Just tell us why you're going to go to number 2 in a short sentence. Why is that the best answer to you?
I want to withdraw it. I didn't see the last but not. So I thought the reconstruction of the bar will correct. So now for me, it's not the correct one. Can I choose another one?
Yeah, you can choose another one. Okay, while we're waiting there, Kirsty, what are you going to go with?
I think I'll probably go with 5.
Yeah.
Can I just ask 2 questions on this? You say
Yes.
the legs are 3 centimeters short, but both
Yes.
of them are affected. So how?
So okay. And if I wanted to expand it, I'm going to give the blurb that we've got normal looking femurs, and I've got normative values for a child of that age based on the length of the femurs and the overall length of the child. I can work it out. I've got tables.
And then just for 3, you said the multiplier is 3. I'm going to assume that's right. Is
Yeah, I rounded it off. Is 3 what?
3 by 3 centimeters, not 9. So I would say 3 is definitely wrong.
Yeah, okay, so it's wrong. I'll adjust that. So it's going to be 9. It pushes us into a different zone. Yeah, get it.
But I'd say 5 is probably the most correct.
Okay.
Because it's definitely true.
So I just want to point out, and it hinges around this, Ayik. The following is the single best answer with regard to prognosis. So if you look at prognosis, because it's important this, and this is where these things can be so difficult. I don't care about the reconstruction of the bone is going to correct some but not all of the thing, because that's a technicality along the way. I want to know where this child's going to end up. Do you see that?
Yes.
So post-axial deformities, yes, I agree, but it doesn't lead to prognosis. And in fact, either 4 or 5 are going to be the eventual prognosis. It's going to be one of those two. So then I'll give it to Kirsty. Multiple reconstructives are associated with poor outcomes. Okay. I'm just going to go now the Oscar Pistorius, not because I want to go there, but because he ends up at the Olympic Games. His prognosis is excellent function. Do you know what I mean? So, but I would go and maybe if I gave it to all of you guys now and you all came up with the 5, Kirsty, that you got, I would revise it. I would take out one of those 2 and putting something else slightly more or less right. Can you see how I myself would need to just be careful about how these are interpreted? How much weight do I put on this prognosis, for example? Can you see where I think that they're an excellent tool, but we need to treat them with caution because they're going to be very, very, very zoned in, very specific. Okay. And I do think that they require a little bit of practice from all of us, both yourselves and myself, in looking carefully as to what are we actually asking. Does that give some indication of where we go?
Yeah.
Cool. Listen now. So, are there any, I'm now looking here, questions, chats? Nothing's come up that I can see. Nothing on the chat? Pravesh?
Nothing on the chat, nothing, no question.
You, moderator. Somebody else has grabbed somebody's got control of my mouse there. It's amazing. Okay. Right. Any questions going once and twice? No? So I think that's it. Guys, thanks very much for attending.